Good evening, friends. Thank you to all of you for joining in for another interesting series where we discuss about concepts related to medical education, concepts related to diabetes, concepts related to cardiovascular disease. And we have very important topic today, that is diabetes and cardiovascular disease, partners in crime. We know that the prevalence of type 2 diabetes mellitus is huge in our country, and unfortunately, the prevalence of cardiovascular disease is also huge in our country. And actually, one feeds the other. Majority of patients with cardiovascular disease do have diabetes as a comorbidity, and most of the times they do have uncontrolled diabetes as a comorbidity, which leads to escalating risk in the long term. So, to cover this interesting topic, we have a very eminent personality in the field of internal medicine and diabetes, Dr. Prasanth Sankar. Dr. Prasanth Sankar is a consultant internal medicine and diabetologist at MGM Muthoot Hospital, Pathanamthitta in Kerala. He is a MBBS, MD, MRCP, FRCP. He's an internal medicine consultant based in Pathanamthitta, Kerala, and he's also presented multiple works in ADA, International Diabetes Federation. He is part of the governing body of RSSDI Kerala chapter, joint secretary of IMA Pathanamthitta, and he is a very renowned academician. So we are very happy to have you with us, Dr. Prashant. Welcome to the show.
So very good evening to all. First of all, I would like to thank the IGCP and Dr. Sachin Mittal for moderating the session. So we will go into the proper topic. The topic, as described earlier, is diabetes and cardiovascular disease. Are they partners in crime? So this is the prevalence of diabetes in India. We know that the prevalence of diabetes is around 9.6% in adults above the age of 20. But this is the national average. If you look by the regional average, it will be much higher. In a state like Kerala, where I've come from, the average is much high. We have data to show that almost 25% of the adult population is having diabetes. And the number of people with diabetes in India is the second highest in the world. And if you do not control this epidemic, it is soon going to be the first country, topmost country with the country with the topmost people with diabetes. And India, you can see 1 in 11 adults is living with diabetes. And more alarmingly, over 53% of the adults living with diabetes are undiagnosed. So that is these are the numbers about diabetes in India. Coming to cardiovascular disease, according to the International Diabetes Federation, the prevalence of coronary artery disease among diabetic population is 2.5%. Again, this is symptomatic disease, which is based on the studies reported, but we know that there is a lot of asymptomatic patients with subclinical vascular disease which is there in our community, and that's where we should intervene early in the management of diabetes to prevent the cardiovascular disease. The studies have shown that more than 65% of the patients die of cardiovascular disease, of which nearly 80% are attributable to coronary artery disease. And mortality after an acute coronary event is also 40% higher than in the Asian patients. The Asian Indian ethnicity is more prone for coronary artery disease because of multiple reasons, which we know, because of the abdominal obesity, the small vessel diameter, the atherosclerotic progression, which occurs at a much younger age and rapidly than in the Western counterparts. And you can see when there is more clustering of risk factors, the chances of cardiovascular death increases. This is from the Framingham Heart study. And you can see whether it's a total cardiovascular disease or the coronary artery disease, cardiac failure, intermittent claudication, or stroke in patients with diabetes, there is a relative risk which is increased more in those with diabetes compared to non-diabetic patients. And this is seen in both men and women. And there are circumstances where we can see that women are more prone to cardiovascular disease than men. So these are the risk factors for cardiovascular disease in diabetes. There are multiple factors which have an interplay which finally leads to atherosclerotic progression. You have the increased insulin resistance, the role of pancreas and hyperinsulinemia, hypertension, genetic predisposition, which is very important, the advanced glycosylation end products, the thrombosis which occurs. There is increased chance of thrombosis with the insulin resistance, and the dysfunctional adipocytes and the TNF alpha. All these things produce increased atherosclerosis. They provide or they create a pro-inflammatory state thereby accelerating the atherosclerotic progression, leading to cardiovascular disease. And you can see the hyperglycemia and the oxidative stress are cornerstone in this mechanism. There are multiple pathophysiological mechanisms which are acting there. You can see multiple molecules and multiple pathways which are involved in the atherosclerotic process and in the pathogenesis. Finally, what happens is that there is arterial occlusion and the patient gets a cardiovascular event. So there is oxidative stress, there is low-grade inflammation, and there is endothelial dysfunction. And what we have to focus is on the prevention of cardiovascular disease in diabetes as physicians and diabetologists, because once the cardiovascular event has taken place, then it is secondary prevention where the role of the cardiologist comes in. But by large, it is preventable by taking proper appropriate action at an early stage when the disease is in the subclinical stage, or when you have a patient who is at high risk of getting a cardiovascular disease. So it can be prevented or delayed by controlling the blood glucose, controlling the blood pressure and cholesterol, and with lifestyle changes such as stopping the smoking, eating healthy, and increasing the physical activity. And the primary prevention, as you know, it involves delaying the new onset CVD in patients with type 2 diabetes. And secondary prevention, as I said, it's the treatment of risk factors in diabetic patients with established cardiovascular disease. So what are the therapeutic strategies? Early initiation of combination therapy in type 2 diabetes is recommended. All the latest guidelines stress on early aggressive therapy to achieve the glycemic control, prevent the beta cell deterioration, better preserve the beta cell function, and prevent the progression of the vascular disease. And we have multiple novel medications which have proved their safety and efficacy in controlling the progression of disease, not only controlling the diabetes, but also controlling the prevention of controlling the progression of cardiovascular disease, and both in primary and secondary prevention of the cardiovascular disease. We have the gliptins, we have the SGLT2 inhibitors, and the GLP-1 receptor agonists, which all have undergone a multiple number of studies involving many thousands of patients, and we have all the results in front of us. Coming to a combination of SGLT2 inhibitor and a DPP4 inhibitor, which is considered one of the most efficacious and the safe and the most suitable drug in our population, because of the multiple risk factors of the Indian population. This combination works synergistically to achieve not only the hyperglycemia but also the extra glycemic benefits like the cardiovascular safety and the cardiovascular benefits, the renal benefits, and the other metabolic benefits. And these combinations bring safer, rapid, and sustained glycemic control. They improve both the insulin resistance and the beta cell function. They help reduce the body weight and the abdominal obesity. They have an effect on the blood pressure, the hepatic fat, the uric acid, and the use of fixed dose combinations definitely reduces the pill burden. And overall, these drugs are cost effective in the management of diabetes. So not only will they prevent the hyperglycemia, they will help in preventing the complications of diabetes like nephropathy and cardiovascular disease. And even in patients who are on a secondary prevention stage, these drugs will help in preventing the progression of the established disease, as we have seen in the trials. This is a declared TIMI trial with dapagliflozin, which all of us know, which showed that dapagliflozin was non-inferior to placebo with respect to the primary safety outcome and significantly lower rates of cardiovascular deaths and hospitalization for heart failure. So this is slide which will be the last slide of our presentation. I think we will stop the presentation here, and I hand over the session to the moderator for taking up the discussion part.
So, Dr. Prashant, we know that insulin resistance is something which is very, very common, and insulin resistance also has a relationship with endothelial dysfunction. And endothelial dysfunction, we know that leads to a plethora of problems in the long run. So how do insulin resistance and endothelial dysfunction actually interplay in the context of diabetes related cardiovascular complications. If you can shed some light on the interrelationship between endothelial dysfunction as well as insulin resistance in the context of diabetes mellitus, that will be very helpful for the listeners.
I have described it's something termed as the common soil hypothesis, where the cardiovascular disease can start at the onset of diabetes. They both share a common platform of pathophysiology, and insulin resistance is one of the key players of inflammation, which leads to inflammation and endothelial dysfunction in patients at risk of getting a cardiovascular disease. So, in patients with diabetes, especially poorly controlled diabetes, there is a risk of getting additional cardiovascular death, and the mortality rate is much higher, as we have seen in the slides. And along with additional risk factors like hypertension, obesity, the risk doubles or triples and even becomes 5 times compared to a patient without diabetes.
So thank you very much, Dr. Prashant, for the detailed answer. At this point of time, my mind wanders to a disease called atherosclerosis, the disease process called atherosclerosis, which leads to cardiovascular disease, which, insulin resistance and endothelial dysfunction feed atherosclerosis, and it leads to a higher complication of cardiovascular disease. So what are the distinctive features of atherosclerosis in people with diabetes compared to those without diabetes? And how does it actually impact the cardiovascular risk?
Yes, we know that in patients with diabetes, it's a multi-vessel disease which happens. The atherosclerosis occurs more rampantly, more rapidly, and it is more diffuse than in patients without diabetes. So we see that the patient with diabetes is not only getting a single vessel disease, he usually gets a multi-vessel disease. Like the patient is not very often, we see that the patient is not often suitable for an angioplasty. The patient will need a coronary artery bypass, and the peripheral vasculature is also equally affected. The patients will have a peripheral arterial disease. We see that the ankle brachial index is reduced. There will be the carotid atherosclerosis, the peripheral atherosclerosis, even the renal vascular flow is impaired. The renal atherosclerosis is also often present in patients with diabetes. So it's a diffuse vascular disease which happens in patients with diabetes compared to those patients without diabetes.
Thank you, Dr. Prashant, for a lovely, elaborate, and a detailed answer. At this point of time, we need therapies which can, impact the outcomes in a positive way. We need therapies who can help our patients live longer, live better. So, how do newer anti-diabetic medications like SGLT2 inhibitors, GLP-1 receptor analogs influence the cardiovascular outcomes in diabetes patients?
We now have multiple studies, right from the EMPAREG study and the declitimi study, and those studies with the liraglutide and the dulaglutide. All the studies have shown that these molecules are safe in patients with cardiovascular disease. And when it comes to the secondary prevention, both the GLP-1 receptor agonist and the SGLT2 inhibitors have shown that they help in secondary prevention of a cardiovascular event. And the GLP-1 receptor agonists have also shown a role in the primary prevention of a atherosclerotic cardiovascular disease. When it comes to the heart failure, SGLT2 inhibitors have an upper hand. They have shown their efficacy in both the primary and secondary prevention of heart failure. Even in patients without diabetes, we have multiple studies like the DAPA-HF, which has shown that it helps in the prevention of heart failure and related cardiovascular death in patients even without type 2 diabetes.
So thank you, Dr. Prashant. At this stage, we must not always forget that while medications play a huge role, there is no substitute to lifestyle intervention. There is no substitute to having a good diet. And that is something which is very, very important for a large number of patients. So how do lifestyle and diet play a role in that? And can you kindly elaborate on the lifestyle measures, including diet as well as exercise, and their role in mitigating type 2 diabetes, as well as the associated cardiovascular risk in patients with type 2 diabetes?
Lifestyle interventions in patients with cardiovascular risk and in patients with diabetes, we know that the first and foremost step in managing any metabolic disease is a lifestyle, whether it's diabetes, cardiovascular disease, whether it's a fatty liver or obesity. Lifestyle modifications are there in the top. So it includes the pillars of lifestyle modification, as you know, like maintaining a healthy diet, doing regular physical activity, maintaining a good sleep. It's very important that you get 6 to 8 hours of sleep, reducing your stress, remaining calm. You have to maintain good relationship with your family members and your colleagues. It's very important to maintain a positive relationship, and you have to avoid risky substances, whether it's alcohol or whether it is smoking. You have to avoid that, and you have to monitor your sugars and blood pressure and your body weight. All these are very important when it comes to the management of the lifestyle management in patients with diabetes, not only diabetes, with cardiovascular disease and the whole spectrum of cardiometabolic disease. And this is one thing which can help in both the primary, the primordial, the primary, and the secondary prevention of these diseases. And it should always be emphasized before the start of any treatment, or even when the patient is continuing the treatment. All these things should be emphasized to the patient.
Thank you, Dr. Prashant. Well, when we are looking at a primary care setting, the first and the most important thing is the cardiovascular risk assessment. And we know that in our country, with huge number of people suffering from diabetes, crores and crores of people suffering from diabetes, it's sometimes, it's difficult to do justice to all the patients with overstretched healthcare infrastructure. So, what are the challenges and the opportunities at the same time in implementing comprehensive cardiovascular risk assessment in the management of patients with type 2 diabetes mellitus in the primary care setting?
The challenges, if you look at the challenges and opportunities in implementing the comprehensive cardiovascular risk assessment, again, the problem is that there are a lot of silent disease in the community. As we have said, almost half of the patients with type 2 diabetes is undiagnosed, and even in those patients with diagnosed diabetes, only half of them are getting proper treatment, and in those who are getting proper treatment, only half of them are controlled. And the same happens with cardiovascular disease. A large number of patients are remaining remaining silent, or they are not doing enough screening test for proper timely detection. And it's our aim, or that should be our aim, that we should screen these patients for early cardiovascular disease. We should look at the multiple risk factors. If the patient has got multiple risk factors, we should screen the patient with cardiovascular disease. We have many screening tools which are available for screening of cardiovascular disease and the renal disease, like we can use the biomarkers. We can use an ECG or a treadmill test, or the other cardiac biomarkers like a BNP, to detect preclinical or clinical overt cardiovascular disease. And the intervention should be started at the earliest. Even before starting the intervention, it's very important that a patient with diabetes naturally falls as a high-risk cardiovascular patient, and the patient should be started on a moderate to high intensity statin to prevent a cardiac event. So that is regarding the risk assessment. And the problem is that because the disease is silent and asymptomatic, it is very difficult to convince the patient regarding the risk of this disease. And patient education and awareness is very important. Like, it should be through your hospital, through your clinic. It should be hugely emphasized through the social media, which most people are using now. Any type of medium, whether it's a public it's a live telecast, or it's a social media video, or it's a physical conference or a meeting which is there, or an educational platform which is there. It should be maximally reaching the patients, and the patients should be educated about the problem of diabetes and cardiovascular disease, and the complexities of these two diseases, and the complications that can happen if you do not control these diseases together.
Thank you very much, Dr. Prashant. So, one very important complication of type 2 diabetes mellitus that we very commonly see, and which is actually considered a surrogate for a cardiovascular disease, that is albuminuria, that is diabetic nephropathy. Diabetic nephropathy is something which leads to a higher chances of cardiovascular mortality and morbidity that we all know. So, can you shed some light on this diabetic nephropathy? As how does it contribute to higher cardiovascular mortality and morbidity? And what we can do to ameliorate its effects? What are the implications of treatment if the patient has a diabetic nephropathy in type 2 diabetes mellitus or even in type 1 diabetes mellitus?
The diabetic nephropathy, which is again a big reason for the morbidity and the mortality, especially in patients with advanced diabetes. And we have multiple markers which are there for diagnosing diabetic nephropathy. Again, the cardiovascular mortality is increased in patients with diabetic nephropathy compared to a patient without a diabetic kidney disease. The mortality is 2 to 3 times higher. The cardiovascular risk and heart failure risk is 2 to 3 times higher in patients who are having a nephropathy. So we have to diagnose a nephropathy earlier. And all the guidelines tell that you should do a urine albumin excretion, urine albumin creatinine ratio, and serum creatinine, and do the eGFR. The estimated GFR is the one which should be done, not rely on the creatinine value itself. And that should be done at the first diagnosis itself. And if it is negative, it has to be repeated yearly, at least yearly. And if it is positive, it has to be followed up much more frequently, and the therapy has to be started. And early intervention is now possible because of the use of SGLT2 inhibitors, the GLP-1 receptor agonist, and the antihypertensives like ARBs and ACE inhibitors. And you have drugs like spironolactone, you have finerenone. All these things are available in the market. And early aggressive management of the kidney disease is very important for further prevention of two things: not only the progression of kidney disease, but also prevention of the cardiovascular disease.
So thank you very much, Dr. Prasanth. So what are the emerging biomarkers or imaging modalities which can help us do an early detection as well as risk stratification of cardiovascular disease in patients with type 2 diabetes mellitus? We know that, lots of patients with cardiovascular disease, they come with an event, right? And once there is an event which has already taken place, it's very difficult to do a long-term good justice to the patient, long-term good quality of life to the patient. So the real benefit we can give to the patients if we can help prevent an event. In that context, the role of biomarkers become important. So what are those emerging biomarkers or imaging modalities which we can use for such an early detection and help the patients achieve the outcomes in a better way?
Yes, we have we have to remember that the most important thing about the cardiovascular disease is that it may remain asymptomatic for a long time. So biomarkers, whenever indicated, it should be done, especially in heart failure. We have markers like the NT-proBNP, which is there, which can detect subclinical heart failure in patients with a high risk of heart failure with multiple risk factors and mild symptoms. You can do a screening with an NT-proBNP, which is easily available. You can do an echocardiogram, which will be helping you to detect the LV function. It's not only the heart failure with reduced ejection fraction, which is there. The heart failure with preserved ejection fraction is more common in patients with diabetes. Again, it can be detected with the help of an echocardiogram. And SGLT2 inhibitors have shown that it's beneficial even in patients with heart failure and preserved ejection fraction. Across the spectrum of heart failure, it is effective. So if the patient has got evidence of heart failure, you have to institute the SGLT2 inhibitors into the treatment at the earliest. And you have other imaging modalities like the CT coronary angiogram, and you can use the coronary artery calcium score. And if the patient has got a calcium score of more than 100, you have to intervene the patient with probably a higher dose of statin and antiplatelets whenever necessary. If the calcium score is significantly high, you have to send the patient for a conventional angiogram and do the corrective measures as per the result. And the simple screening with a treadmill test and ECG can be helpful in most of the patients. So we have all the facilities available. It is widely available in most of the hospitals, even in the, not only in the big cities, even in the small towns and villages, we have facilities for doing all these things. The lab networks are now widely established, and it's very important that as physicians, we should encourage the patients to screen for this disease, screen them, and if there are signs of subclinical disease, the therapy should be initiated very early so that we can get control over the progression of the disease.
Thank you very much, Dr. Prashant, for a nice answer. Well, we know that many patients with diabetes do not take therapies properly. They are always worried that, maybe if we take the therapy, if we take this medication, this patient medication may cause our sugars to fall below normal, or this medication might not be good for my kidneys or might not be good for my heart. These are very, very common misconceptions and myths that are there. But at the same time, now we are living in an era where medications not only help the glucose control, but they also help better outcomes in terms of cardiorenal outcome parameters, as well as do not increase the risk of hypoglycemia per se. That is, they're anti-hyperglycemic, not hypoglycemic medications. So this is especially relevant in patients with cardiovascular disease. So what strategies we can use in a patient with diabetes and coexisting cardiovascular disease, where we can optimize the glycemic control for the patient without subjecting the patient to an undue risk of hypoglycemia?
The biggest issue, as doctor has said, regarding the management of diabetes is the hypoglycemia, and this is where the role of newer anti-diabetic agents come in. So we have to establish a good glycemic control, a tight glycemic control, but we have to make sure that this glycemic control happens without the consequence of hypoglycemia. At any cost, it's very important to prevent the patient from going into hypoglycemia, especially those with a cardiovascular disease are at increased risk of hypoglycemia because again, advanced cardiovascular disease, you can have hypoglycemia unawareness, and on the other hand, those patients with advanced diabetes and hypoglycemia unawareness, they are prone to cardiac arrhythmias when they get a level 3 hypoglycemia. So at all costs, you have to prevent hypoglycemia. Use agents which prevent hypoglycemia or which have minimal chances of hypoglycemia, like you can use a metformin, you can use a dapagliflozin, you can use a gliptin like a sitagliptin or a vildagliptin, and you have the other agents like the GLP-1 receptor agonist. Even if the patient is on an insulin, you can use insulins like the basal insulins, the ultra long acting basal insulins, which are available there, the Glargine 300 and the Degludec, or the co-formulation of Idec-Asp. All these are proven to have less hypoglycemic effect while maintaining a very good glycemic control. And it's very important to educate the patient regarding the presence of these molecules. These are available in the market, and use them if the patient is at risk of hypoglycemia, especially the patients who are elderly or having a highly labile blood glucose value with high glucose variability. When we see that if you do a flash glucose monitoring, we see that the time below range is much higher and the patient is not keeping the time in range. We have to institute therapies which has got minimal risk of hypoglycemia, and in most of the patients they will do well with a combination of metformin, gliptin, and egliflozin, like a combination of sita and dapagliflozin.
Thank you very much, Dr. Prashant. It was a very helpful answer, and something which can be the benefit can be passed on to wider number of patients without the risk of hypoglycemia. Well, we know that our country there is a dichotomy. At one end there are people who are where money is not a problem, and at the other end there are a large number of people where finances do become a challenge, and diabetes affects both. It affects the rich and it affects the very poor as well. So there are some socioeconomic factors and health disparities in terms of access to education, access to diabetes care, and diabetes education, which is there. So how do these socioeconomic factors and health disparities influence the intersection between diabetes and cardiovascular disease, and what kind of strategies we can use, we can implement to address these disparities within the healthcare system?
The socioeconomic factors and health disparities definitely influence the intersection between diabetes and cardiovascular disease, and that's why we stress on early diagnosis and early treatment, aggressively treating the risk factors and aggressively treating the diabetes at the early stage. The cost of diabetes and the cost of treating diabetes, the economic part comes in when the patient has got complications which have already set in. So once the complications have set in, we have to treat the complications. The cost of treatment is bigger for the complications compared to the cost of treating diabetes with good medicines. The treatment complications, the treatment of complications, it costs 5 or 6 times, sometimes 10 times higher than the money you spent yearly for the treatment of the disease per se. And earlier, the gliflozins, the gliptins and gliflozins were very costly. The drugs were very expensive, and it was not affordable for the common man. But right now, we have drugs like the fixed dose combination of DAPA and SITA, which is very cheap, easily available in the market, and virtually anybody with diabetes will be affordable for these drugs. And instituting these therapies early means that we are preventing complications in the heart and kidneys. We are maintaining a good glycemic control, and we are preventing the patient for going into the complications, and thereby preventing the cost of the ultra high cost of treating the complications. Along with that, it's very important to control BP with evidence-based medicines like the ARBs and the calcium channel blockers. All these drugs help in controlling the blood pressure. You have to keep the BP as recommended by the guidelines. You have to keep it below 140/90, or if possible, keep it below 130/80, and keep the LDL cholesterol below 70. All the guidelines stress that you have to keep the LDL cholesterol levels below 70. Most of the patients will require a moderate intensity statin, an atorvastatin of 20 milligram or a rosuvastatin of 10 milligram, which will be helping you to keep the LDL below 70. And along with that, the lifestyle factors which we have mentioned, always keep a check at the lifestyle factors, and all these things will prevent the complications, and this will mean that you can manage the diabetes at a very with a very low financial burden, without causing much trouble to the individual and the family and the society.
Thank you very much. Well, we are coming to the end of the show. And one thing which is very, very important is that, there is no substitute for a good patient education program. Lots of patients think that diabetes is just a sugar reading value. They do not think that this is something which leads to higher risk of all complications, be it heart disease, be it kidney disease, be it stroke, be it retinopathy, nephropathy, all these kinds of complications. So it's important for us to, make sure that patients are well educated and aware about the link between diabetes and the cardiovascular disease. This is especially relevant in a primary care settings, because if we are starting at that level, the benefits in the long run in the society as a whole can be huge. So what strategies we can employ to enhance the patient education as well as awareness regarding the link between diabetes and cardiovascular disease in primary care settings?
Yes, that's why these meetings like this are very important. We have to spread the awareness among the primary care practitioners, and these are the people who are seeing majority of patients with diabetes. Diabetes is a disease which should be managed in the primary care settings, and it's not a disease which ideally should be managed in the tertiary care settings or multi-specialty hospitals. The root of the crux of the disease is in the general population, and more than 3/4 of these patients are seeing the primary care practitioners. So it's important to spread the awareness about early management of diabetes, the use of medications which help in early control of diabetes. Use of medications will help mitigate the cardiovascular risk. Use of medications which provide less risk of hypoglycemia, and controlling the comorbidities of diabetes, like controlling the body weight, controlling the fatty liver, hypertension, and dyslipidemia. All these things should reach the primary care providers, and until and unless the primary care providers are educated on the latest happenings in diabetes, we are far from reaching the goal of good glycemic control and preventing the rapid spread of diabetes, because patients reach a tertiary care center or a high specialty hospital only once they have developed some complication, and it is beyond the reach of the primary care practitioner. So it's very important that we conduct regular academic sessions for the primary care practitioners, involve them in the treatment policies, and the message should be dispersed to the primary care settings. And the important message is that diabetes and cardiovascular disease share a very tight link, and controlling one disease is important for the control of the other.
Thank you so much, Dr. Prashant. It was a wonderful interaction with you.
I thank the moderator, Dr. Sachin, for again engaging with very important questions, which is very important for the discussion. And all these points have been clarified in detail. And I hope this message is carried forward to the primary care community. And once again, I thank the organizers for providing me this platform.